Welcome back to another episode of Life's Ambition podcast. Today we are joined by someone who is driven and tenacious in their line of work. He's going to give his input on becoming a spine orthopedic. Without further ado, Dr. Ronjon Paul. All right, Dr. Paul, how you doing?
Good. How are you, Drew?
Good. I gotta say, now things are starting to get a little bit cold in North Carolina, so we actually got some sleet yesterday on the way to a Canes game. So who would have thought there would have been snow in Raleigh?
Whoever thought there would be hockey in North Carolina, but apparently it's been a thing for a few years. So,
Well, yeah,
I'm
last year, last year we sold out, or 2 years ago now, sorry. The years just kind of fly by, I feel like, as you get older. But at the Carter Finley Stadium where NC State football plays, they did the outdoor game there for the Carolina Hurricanes versus the Capitals, and it was like 55,000 people, and it's like the second highest attendance. It was crazy. It was absolutely crazy. But I love, could talk about hockey all day, but I'd love to talk about you and get to know you a little bit more and figure out, how did you get into the spine orthopedic world? I've never heard of anyone before in it, so I'd love to learn more about it.
it's a long journey, and I'll try and make this as it's not a linear sort of path, but so a little bit about me, sort of my upbringing, my background. So I'm from a medical family. I think fifth generation in line with being in healthcare. So I had a great grandfather in India who started a pharmacy and a clinic, and a great grandfather followed, and then a grandfather who is a primary care doctor who worked there, and then my dad, who also went into medicine, but then emigrated to Britain and then in the United States. We talk a little bit about that later, but obviously, so medicine was a big part of my upbringing, and most of my parents' friends, my quote unquote aunts and uncles in the small Indian immigrant community, were physicians. So that's sort of what was all around me. I was really comfortable with. So I went to look at different options, business, medicine, other sorts of things. And most of my upbringing was sort of a hardcore academic. Most of the schools I went to were very along lines of liberal arts and academics. So medicine melded really well with a lot of the basic science component of that and some of the interests that I had in basic science. So I leaned in that direction, was looking at economics and business. I was an economics major as an undergrad. And then as things evolved, I realized I did want to go into medicine, but I really had a very specific bent on what kind of medicine. I wanted it to be something that was really very tangible with lots of immediate results. So my father was an endocrinologist, and endocrinology is the kind of field in medicine where it's hormones, glands, diabetes, that kind of thing. And you follow patients for years and you make changes in their medications, and it's hard to know what your results are, maybe for months. That wasn't for me. That wasn't for me. I wanted something that was really more hands-on and had immediate results and things that were very tangible. So that meant, from what I could tell, surgery. And the surgeons that I knew of, that I heard were the happiest and sort of the stereotype of orthopedic surgeons, they're athletic, and I was moderately athletic as an undergrad, and they it seemed to be like maybe it's something I should look into. So went to medical school, and it turned out that I was a student representative to the board at my college, and there was I was talking to some of the board members and got to know a lot of them very well, and really met some amazing people on that board. And they said, "Oh, you're interested in medicine, huh?" Well, one of our board members is a gentleman named Bill Harris. And it turned out Bill Harris was this landmark iconic figure in total hip replacements, one of the godfathers of it. And I didn't know who he was. And they said, well, if you're interested in medicine and maybe surgery, and this sounds a little bit like what you want to do, go talk to Dr. Harris. And so I went up to Dr. Harris and shook his hand and chatted with him for a little bit and said, can I come work for you? Can I come work in your lab? And he said, sure. And then he pointed me in that direction. So I went to talk to, so I went and after I graduated college, I was all set up to go to medical school. I traveled for a few weeks and then came, when I got back into the country, went directly to Boston and started work in his lab. So when I started working there, it was on, I didn't know the first thing about total hip replacements. I knew they were really amazing, like the concepts. So I wanted to learn more and more about orthopedic surgery. So I showed up. He had this very, if you, surgeons start their days really early, like 5:30 and 6 in academics. I think this is like a 6 or 6:15 conference that they had every morning. Not every morning.
Why so early?
Sorry?
Why so early?
Because their day started at 7:30. The operating room started running at 7:15, 7:30. So if they were going to have a morning conference and discussion, sometimes they did that before rounds. So maybe a half-hour conference, 45-minute conference. So that would take you to 6:45, and then you needed 45 minutes to go see all your patients on the floor. And then people were rolling into the operating room at 7:30. You had to be there to get things squared away and start working. So yeah, I would show up and I would just be a fly on the wall. I would just kind of listen and just learn about how they plan cases and sort of the creativity that went into it. And then sure enough, after a while, I'd follow them around on rounds. And I could tell what, just from the descriptions, what they were doing was pretty dramatic in the operating room. And total hip replacements were very different. So this is in the early 90s. And Bill Harris was actually a very traditional surgeon. He was he was an icon, but he had a traditional way of doing things, but it was very predictable, great results. And I would see how the patients were doing, and I kind of had a sense of how much pain they were in prior to surgery. And they were doing, despite how big these operations were back then, they were doing amazingly well. I mean, all these operations were life-changing. And then I would come to go to clinic, and I said, this man is changing lives every single day, every time. These surgeons, every time they walk into an operating room, they do just amazing things.
It's like clockwork for them too, to be able to do it every day, day in, day out, because they're seeing so many patients. And like you said, there's probably so many surgeries. Your clock starts at 7:30, whether you like it or not. Like people are in there and you got to go. And it sounds like, why do you say he does the traditional way of things? Like what's the difference between doing traditional versus a different way? Is it very much by the book?
No, he just, so, well, let me, in graphic terms, he had an incision that was probably 12 to 18 inches long on the side of a hip. And the operations took 2 hours, 15 minutes, plus or minus 5 minutes. They were very predictable. There's a set amount of blood loss. The technique was the same every time. And all this had a big influence on me and how I practiced later in life and do spine surgery. And whereas other surgeons, even at the time and then later on, started doing much smaller approaches or alternate approaches to the spine. And nowadays, if you go to see a total hip surgeon, you're probably having maybe a little incision on the front and it's outpatient. I mean, his patients were spending 3 days in the hospital. Again, this is, what are we talking, 30 years ago? But even then, he was a little bit more traditional in how he did things. Because he had been doing it at that time, I think for 20 years or something. He had been doing hip replacements when people really weren't doing them. So that's what I mean by traditional. I mean, gotcha. Really outstanding surgeon. This is an internationally known guy who basically did some things with hip replacements involving how they were fixed in it did some of the earliest research in how to properly use cement versus bony on growth on different components of a hip replacement, and changed the whole world of hip replacements pretty early in his career.
I'm just thinking like 12 to 18 inches that's a significant cut through the leg almost to get a total hip replacement. So I'm just thinking about the rehab in my head of, oh, that's got to be painful. Where you hear smaller insertions where, um, I guess, do they only replace so much at a time so then your body has a little more time to heal in between each process? Or
Nowadays, so yeah, these hip replacements are what, under 5 inches. Some of them will do them to too little incisions, and yeah, the rehab is completely different. The rehab. I mean, they would get out of bed the next day after these bigger operations, but now people are getting these done in ambulatory surgery centers, and they're just walking out of the hospital. It's completely different. Yeah, it'll blow your mind. But again, 30 years ago, you would hope there'd be some progress in 30 years in how we do things, and we do a lot more of them now. So Dr. Harris I would come along in rounds, and I thought this, and then I got to know the residents, and then I started following the residents around. I actually started taking call with them. I would just follow them around and shadow them overnight. None of this would happen this easily today. Nowadays, like you'd need a lot of paperwork and credentialing and this. I was just some kid off the street out of college, and they had me walking around helping out the residents and helping them with rounds and everything. And I was a lab rat. I was just a kid in the lab, and I found this stuff amazing. I found it addictive right away. And so as time goes on, so there's one particular moment in which I came in for rounds, and they said, kid, you're up. I said, what do you mean by I'm up? Said, well, next time we meet, the resident, no, it was the fellow at the time, had to go take his boards. He had to take an exam for the end of his orthopedic surgery residency, which they all do. And he's not going to be here in town. He has to go to Chicago to take an exam. So you're going to be stepping up, and you're going to help out in surgery. You're going to hold the leg. Again, this would never happen today. So you'd never, anybody young listening to this, like, you can't just walk in and ask people, even if the surgeon wants you there, it's like there's a million hoops to jump through to do anything like this. It's early. And this is at Massachusetts General Hospital. And so I said, okay, I'm in. So Dr. Harris, who is this icon of a guy, literally met me at the front of the in front of the ORs, and walked me into the operating room, shared his locker, showed me where to get my scrubs. I mean, really, really basic stuff. Just so kind. This guy is just so kind and generous with his time on an operating room day when the schedule's tight, and showed me how to wash my hands. And operating weight total hip replacements are done back then, are still done today with, it's not just a standard mask and hoodie or hairnet and things like that. They wear these huge helmets, and there was special ventilation coming out. You have to hold your breath while they put all the stuff on you. So I mean, this is all kind of, I've never been in an operating room really before. And then I've got this laminar airflow and this helmet on, and then I'm confronted with this. I really hadn't had breakfast either. It was really early when I got into the hospital, and I'm confronted with this 12 or 18 inch incision. And in old school hip replacements are sort of a garish affair for the uninitiated. And I loved it though. I mean, the whole thing, and how the tools were used and how precise everything was, and just the technology. And I was addicted right from the beginning. So I was like, well, I'm going to be an orthopedic surgeon. That's it. That's what I want to do. So I finish out the lab year. I continue working with the residents, and I got my mind made up. And I want to be I want to be a total hip surgeon. That's exactly what I want to do. So I go to medical school. I start up and I get through the first year or two, and I get through my rotations. I do. I love surgery. I actually love all the fields in surgery. I think they're just amazing. Real respect for internists and how their brains think and how they work. My dad was an internist, so my grandfather was too. So I obviously have a lot of respect for them. But surgery was really where I wanted to go. So I go through the whole process of applying to orthopedic surgery. It's not an easy process to get into. It's hard enough getting into medical school. Then trying to get into a surgical subspecialty like orthopedics that's really popular. Luckily, I had a lot of research in my background and I had guys like Bill Harris pulling for me. But I got in. I ended up getting into orthopedic surgery. And I start going through do my internship, which is a whole conversation in of itself. It's an interesting year. Start going through my rotations in orthopedic surgery. And one of the early rotations was total hips, and knees, the arthroplasty service, and doing them and really enjoying them. And I loved how it was just like Dr. Harris in the sense that there was a set process for how they did things. And it was very predictable in a lot of senses in a good way. So for a young resident trying to think their way, it gave you a good framework in terms of how to think through an operation. We were very well supervised, but that was actually like a total knee replacement, total hip. That's a great way to learn how to be an orthopedic surgeon because it's the same steps every single time with it's somewhat an algorithmic approach. It's similar steps. You just had to follow them in a very constructive manner and think through the problems. You always had some answers to certain challenges in any operation. So it was a good way to become a young surgeon. But I also realized, so again, that total hips and total knees were at a point where I knew they would improve. I knew they were going to ask, and everything I knew as when I was that young undergrad, a person that just graduated college, those things were still true about hip replacements and joint replacements. But I wasn't sure that they had quite as much technology to run as some of the other fields in orthopedic surgery, particularly spine. So one of my rotations was on the spine surgery service, and spine surgery. So this is in the mid 90s, late 90s. Spine surgery was evolving really rapidly. I could tell in some ways it was really behind things like sports medicine. Like they had no evolution into like the equivalent of arthroscopic surgery. They hadn't been through kind of the big technologic changes. And spine surgery was very similar to me. Some people would maybe find this surprising because it's not the reputation of spine surgery, but when done for the right situations at the right times, spine surgery is extremely beneficial for patients. I mean, their pain would, if you get pressure off of a nerve, I would see people in recovery room and their pain was gone. People with severe stenosis, you remove their stenosis, they start feeling good right away. Now, it's not always quite like that. People need time, but it seemed very tangible. It had a lot of things that I loved about joint replacements. And I knew the field had a lot of room to grow. And so I was like, so I'm thinking to myself, well, I think spine surgery might be a really something I ought to look into. And I looked into other fields too. I loved hand surgery. Hand surgery was the other one that I really loved too. But spine surgery seemed like it had a lot of room to evolve. So that's how I ended up applying for a spine fellowship. There were a lot of people at my residency that that advocated for people to go into spine surgery, for me to go into spine surgery. So that's what I ended up doing.
I think that's a really cool beginning to how you met Dr. Harris and how you are to where you got now in terms of getting your residency and all that stuff. And I kind of want to go back a little bit and talk a little bit about your family history. You talk about how you're a fifth generation as in becoming a doctor. Did you always know that you wanted to do that? Was there ever a thought of like, hey, like, do I want to do something different outside of what my family already does?
Oh yeah, yeah. There was. I really looked into finance, and I was an economics major. I went to Haverford College. It was a small liberal arts college, and pretty much the people that went there, you did one of a few things. You went into academia. You went into some kind of academic field with postgraduate degrees or things like that. Or you went into one of the professions, medicine, law, or you went down the business route, and the business route tended to be consulting or investment banking at that time, or some kind of finance. And a lot of the econ majors at Haverford were investment banking was big at that time. And I actually spent some time in Manhattan, did an internship one of the other years, and actually spent a little bit of time at a sort of a summer form of a business school, actually at University of Chicago, and looked into it actually pretty deeply. And it was actually an investment banker that I said I was, at the time, I had some leads that I knew I was likely going to have an opportunity to go to medical school, and was kind of having this heart to heart. It was an investment banker who said, nothing against investment banking. This is just what one of them said, and they had a massive influence on me. Said, why are you even having this discussion? I said, if I had to do it again, I think medicine's way more rewarding on a day-to-day basis and way more purposeful than iBanking. And this is a very successful iBanker. This is somebody who financially did extremely well, was very powerful on Wall Street. They worked for one of the big bulge investment banks.
Do you
And
ever ask him why he said that?
I think this goes back to one of the things that I found out, and continues to ring true with me when I talk to my contemporaries that went into other fields. And you need to have a real good reason to get out of bed every day, and a real sense to work with a sense of purpose and passion. And that was very obvious in orthopedic surgery, and particularly spine surgery. So it got me motivated to go that direction. Now, I was really interested in economics, and I loved markets, and maybe I would have loved iBanking. I don't know. But this iBanker, this one, for whatever reason, maybe they were just having a bad day or a bad week. I don't know. They were, I think they seemed to articulate that they did not have that sense of purpose, that the sense that I just don't think they found the field that rewarding. I know financially that person was doing extremely well, but I think they might have been a bit burnt out, and that's not uncommon with a lot of fields that are out there. Again, having a reason to get out of when I was that lab student getting up at 5:30. I mean, at that age, that was kind of that was a little obscene to me. It was very hard to kind of stomach, but I had a reason to do it, and I loved what I was seeing, and was doing it for free. It didn't seem to matter. And I think that person in iBanking they lacked any of that kind of motivation. They just didn't have it.
Well, and I find that as a really big point that you made there is you have to find a passion to wake up every day. And I find that a lot where, that's kind of the whole reason of doing this is to show people what else is out there, because I don't want someone to wake up one day and they're 50 and they're like, what just happened with my life? Like, I wish I did this career. I wish I decided to do that. Because, when I grew up, a lot of people would hear about, you can become, like you can become a doctor, you can become a banker, you can become a engineer in some civil architect company, but you don't really get to hear about the other stuff. Nor in the becoming a surgeon do you get to hear about like what exactly is there, whether that's, like you said, hip surgery or total hip replacement. There's spine orthopedics. Like, you never get to hear about that unless you know someone, or you have an internship experience or real world application because I find that part is missed out in the school system itself of showing you these different things that are out there. And so maybe it's different in the medical world because you have those all those years of schooling after your undergrad in terms of medical school. Because how long were you in med school for?
Yeah, so so this is the issue. My problem with the medical world as compared to so many of the other fields that are out there is that they, and I think it's gotten much better in the last 30 years. Back in my era, people didn't take gap years or anything like that. You had to know you were going to medical school, or at least thinking seriously about it on my freshman year. So you have an 18, 19-year old who has to make a decision as to whether or not they want to take their pre-med classes. And you had to take it, I think there's 6 or 7 of them, like a bunch of pre-med classes. You had to have them done by your junior year so you could take the MCAT. And then if you got the right score on the MCAT, and by the way, you had all the research and all this other stuff on your resume, then you could apply as a senior. So now you're 21 years old when you're applying to medical school. And then I mean, that process started so early. Who knows they really want to be a doctor when they're 18? I mean, you think you do, but there's so many other fields. So I know a lot of people now going to medical school maybe started that process later, and they take those classes and then have to take a couple years and do the MCAT. And getting into medical school is so much harder now, I think, than it was. The amount of research and the kind of the selectivity for medical school has gone up and up and up, especially for U.S. medical schools. And I think that's too bad we don't have more spots for MD and DO spots here in this country. But that kind of process starts so early. So when you say medical school, you asked me how many years were you in medical school. So I would tell you that the undergraduate experience is a bit part of that. So your undergraduate experience, first of all, you have to do extremely, your undergraduate experience is a little bit like being an engineer. Engineers have to know this very early, and their course demands are huge. Like engineering undergrad is like going to graduate school. It is a completely different sort of thing. And I think being pre-med is too. And you have to score extremely well on all your grades and do well on this test. So I consider that part of the medical school experience. And then you go to medical school. That's another 4 years. Some people nowadays, especially for the elite subspecialties, are taking extra time out to do a year of research and do other things. If you're fortunate enough to get into the specialty you want, so that's going to be for primary care, that's on the order of, I think, about 3 years, 3 to 4 years. And then for the surgical subspecialties, that's usually, I think, between 5 and 7. And if you have research thrown in there, I have a very good friend of mine. One of my best friends is a pediatric surgeon. And he and I were residents and interns at the same time. And I think it took him he was in the medical training process, an extra 3 or 4 years between fellowships and research. And he's in pediatric surgery is a highly academic, very, very selective subspecialty. And he's just, his name is Carl Christian Jackson. He's just an amazing physician. He's out, he practices in Rhode Island and Massachusetts now. And he and I went through at the same time, but I think it was an extra 3 years or something before he wanted to practice after me. And I did a 5-year residency directly after medical school, and then on top of that, most of us do at least one fellowship. Nowadays, it's more than one sometimes. So, and my fellowship was a year in spine surgery. So,
wow.
So that's 10 years. For me, I went straight through. I was as young as they coming out. I think I was 32 when I went into practice. That's fast-tracked. That is truly fast-tracked.
And you talked about how you were an economics major in your undergrad. So you were managing to do your MCAT and all that stuff during that time?
It's a little bit like double majoring. I could not. I wanted to do a semester abroad. I couldn't do that. I had to have all my ducks in a row very early, and luckily I went to a college where getting the classes that I needed wasn't. It was a small liberal arts college. It was like 300 or 400 students a year or a class, so it was very. It was easy to get the courses I wanted, and they were flexible in some ways. Um, about economics and being pre-med, I actually was at the time there was a program that was offered during my junior year of college called the Chicago Business Fellows Program. And it's long gone, but back then they had about 10 or 15 liberal arts colleges around the country, and they were having a tough time getting liberal arts people into. They wanted more of them coming to the business world and coming to the University of Chicago Business School. So the U of C back then it's called the Booth School. You could apply, and every one of these colleges, these 10 or 15 schools, would take 1 to 2 people, and you'd spend a summer at the business school. And they also gave you admission to the MBA program that was open. It was a very generous program. They gave you free tuition for a summer, and you could
That's
you
awesome.
get admission to the business school. And that opened my eyes a lot that summer. So that was sort of my big opportunity in getting some insight into the business world that did actually carry forward and give me a lot of help and insight. And at my econ degree, it taught me how to think very analytically, how to think in very, very clear terms. And straight econ degrees are not as business oriented. They're really just study of human behavior put into numeric terms, and then a study into macroeconomics, and it gives you a way to think through policy and other things. But it's not really business school.
Yeah.
It's not. It just gives you a way to think through problems, which I think are highly applicable to anything you do.
I
So
was gonna say, especially for you, that's very applicable because I'm sure problems arise all the time, and even like split second ones where it's like, oh, this just happened right away, whether it's during surgery or someone's like, hey, like this is bothering me here. How can you think through that process?
and that's what a real education is about. And I hope we get back to that with a lot of um, with a lot of undergraduate, and it doesn't have to be college either. It's just teaching people how to teach themselves and how to think critically. Learning things and memorizing things, or just learning pathways. And I mean, anybody can turn on YouTube or read a book. And if you're smart enough or motivated enough, you'll figure things out. And that's what a lot of people are doing, and then good for them. But actually learning to synthesize ideas and come up with new creative concepts and think through a complex problem on the spot, that's what an education is for. And uh, I hope, and people can get that. It doesn't have to be a college again. People can get that in multiple different ways. You can get it at work if you're in the right spot. There are surgeons that taught me how to do that. I had a great residency. I had there are particular surgeons that actually taught me how to think creatively on the spot, but with some rigor where I went. And it was the University of Chicago orthopedic surgery residency. There's surgeons like Dan Mass, John Martell, Larry Pottinger, Frank Phillips. Some of those people aren't in practice anymore. Todd Wetzel. I mean, these people were just brilliant minds, and taught you how to think in an operating room and also in clinic, and and a lot of them taught you how to talk to people, how to relate to people. And that's a whole different dimension that we haven't discussed, but just the education, the emotional intelligence, the emotional IQ, and learning how to deal with people, and how all that works together, I think is lacking. And I think it's gotten better in medicine. I think medicine was really built around picking people that were great at basic science and great at taking
Yeah.
tests. That's changing, I think.
Do you find it hard that you said you fast tracked and ended at 32, where someone who is in investment banking, maybe they took their master's, but they're still starting if they just go right through it at 24 or 22?
So uh, at least my experience in going through this, being a surgeon, um, it's a little bit like being in the military in that you had this very straight path that was very hierarchical. And for most of my 20s and up until I was 32, there was other people who told me where to be, what to do, what my responsibilities were, and they all knew where I was all the time. And I mean, they really did. My chairman, who cared about us deeply, he knew things again might be a little bit different, but it was they. My life was extremely structured, and although we had all these responsibilities, we didn't either in the sense that we didn't run a practice. We didn't have business related financial obligations. I mean, we had a low paycheck, but it was a fixed paycheck. We kind of, that was all very predictable. Um, for at least in the programs I went through, your employment was pretty much guaranteed as long as you stayed within, you didn't get yourself into too much trouble. And you had to pass tests, and there was definitely a lot of eyes on you. There's some stress involved, of course, doing an internship in these residencies, but things were very predictable and kind of laid out for you. So in the sense, it was like being in the military, but then you get out and you're done, and so you almost feel, a lot of surgeons, and I'm not going to speak for all physicians, because some mature at an earlier process in their earlier mid-20s. I wasn't. I was a really immature medical student and resident. My wife reminds me of that all the time. She met me when I was a PGY2, so I was 28 years old, and took me a few years to figure out that I was supposed to be marrying her. Yeah, because I was like, why should I thought like a young kid. I was like, oh, I'm not getting married. I mean, that's something old people do. It's like, well, I was already 28, 29 years old. My perspective was just very juvenile, and that's probably me as much as anybody. But I think there are some other surgeons some other people in my field that are a little bit like that. It's because we're treated like kids in a sense.
Even though you are in your residency for however many years, you're still 27, 28, but you're treated like kids because you're still learning a lot, which I think is really funny, because someone else in their career is like, oh, like, I have a girlfriend, I'm 6 years with this company. I'll start thinking about marriage at 28, 29, and then I'm just going to kind of keep going through, where you still have a very structured process. Like you said, you're in the military, so there's a lot of eyes on you. You're taking exams. You're still in school in a sense, but there's a lot more to it.
Yeah.
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 So that's where I'm like, that's a crazy experience of just how different things are. Like your world's very different than someone else's. You very well could have taken the investment banker route and just been working way before you turned 32 and started your first year.
To be fair to investment bankers, I had a very good friend out of college who went into investment banking and did really well. Their path is a little bit like medicine. I didn't realize that until they do better monetarily early on, but it's not as predictable. It's certainly not as predictable of a future for them because of how higher. It's like more of a pyramid system, really. But they work ridiculous hours.
Yeah.
They work ridiculous hours through their 20s. It's a very stressful environment, can be very abusive, but there is a hierarchy to it. And also it can lead to other things. The nice thing about some like investment banking consulting with these are very rigorous. They're not, I won't call them easier than med school or I like at a high level. I don't think they are. And they can lead to other things on a more nonlinear path. But those people that are just outside of medicine and other business related fields and other, those people tend to grow up a little bit quicker than I think I did. Now, there are a lot of people in orthopedic surgery and surgery that did grow up a lot sooner, and they matured at a younger age and maybe didn't, but it is a strange existence in any of these highly rigorous fields. what goes on during your 20s. And I wonder today, well, a lot of people in your audience that I think are a bit younger, quite a bit younger than me, are uh, they seem things seem to have been a little bit things are a little bit more open-ended, which is good, but people are starting some of their chosen careers because they're trying to find that sense of purpose either in or right after college. They get into that chosen career maybe a little later in life. Could your mid to late 20s, or things evolve maybe in your early 30s. So they're starting their careers a little later too. I think
Hmm.
that's happening as well.
No, that's a good point. I know there's a good amount of my buddies who haven't found anything, but are also unsure of what exactly they want to do. So they'll go out and experiment with just some different part-time jobs, whether that's their local park district or even later on. So they're starting their career later because there is so much new information that's coming out. And like you said, even with the medical world, there's so much new technology that's being put into it that something might appeal to someone later on when they learn about it. And that's kind of how it was for even like myself in terms of learning GIS. Never heard about it until college. Took a few courses. One was a coding course in Python, and we were structured with a project where we had to basically come up with our own project, which really taught me some independent thinking about like what issues affect today. And it was like I did public and private school distribution, and I want to see how that relayed with impoverished communities. And a lot of private schools were impoverished communities just because they didn't have access to public schools. So it was like a different scale, which I actually thought was kind of interesting. But it goes into a lot of independent thinking and also people learning more later on. So they're pursuing their careers later on. And I wanted to sidetrack a little bit. And you talk about your fellowship and even working now. Like, what exactly entails a fellowship itself? Is it just a year at a hospital in your respective, I guess, speciality, or is it something completely different?
So it's a year that and fellowships in other surgical fields can be longer, they can be shorter. But for me, it was a year with a surgeon or group of surgeons in a practice. They may be hospital affiliated. They might be affiliated with an academic medical center. Nowadays, they're not necessarily, could be a private practice. I mean, I'm thinking about putting together our own fellowship where I am now, but that may take some time. There are different ways to do it, but it's a year in a specific subspecialty, a surgical subspecialty. So in orthopedic surgery, that could be joint replacement. It could be foot and ankle, hand, pediatrics, tumor and oncology, sports medicine, trauma. There's at least 7 subspecialties, and so you spend a year, and that's becoming more and more common now. There's a lot of orthopedic surgeons that do two of these fellowships before they come into practice. And the other subspecialties are like that too. So, people are spending a lot more time subspecializing, so to speak, before they go into practice.
I had a talk with Mark Kaufman on an episode recently, and he talked a lot about how the hand in the physical therapy world, it's its own separate entity because there's so many intricacies to it.
Yep.
And I know you said that you thought about doing hand orthopedics as well, or hand surgery. Just like, can you give me a perspective on like the different, I guess, subspecialties? Because I never thought like sports would be a different one. Hands itself is like crazy. I know with all the ligaments, like with the way Mark Kaufman described it, they're very important so you don't develop like arthritis as quickly. I mean, you use them every day. So can you go a little bit into why some of these are broken down into certain categories?
Yeah, the surgeries and the breadth of knowledge in orthopedics has gotten so, and in medicine in general, it keeps getting bigger and bigger and bigger. There's so much more to learn and know, and the procedures have gotten so much more specialized. Well, for example, for spine, most of the procedures that I do now didn't really exist in their current form when I was a fellow. And had to self-teach myself those things, and it takes a lot of time in a specific area to really be able to delve into it and help develop or master those new techniques. And it's like that for the other fields too, I think. Hand surgery specifically is like its own entity because it has elements of working with nerves. Neurosurgery has elements that are soft tissue reconstructive, like plastic surgery. And then it's got arthroplasty, joint replacements. You can replace individual joints in the wrists and the fingers. It's
Dang.
trauma. And the anatomy below the level of the elbow is amazing. I mean, it is absolutely so intricate and so complex.
Just because of the nerves and all the stuff in the anatomy and what you could do with it.
It's the way, if any of your audience is interested, just open a textbook and look at the anatomy or look it up online on the hand and how much of what you do with your hand is actually from the forearm and is just hooked. It's pulleys, ligaments. It's some of the most complex engineering that our bodies are amazing. But the engineering that is just below the level of the wrist and up in the forearm is ridiculous. I mean, it is.
I thought that would have been spine. Yeah, I thought that would have been more spine to be the engineering hold of everything. Because I think about how much your nerves and endings and all that stuff revolve around it. If you get paralyzed, like it's tough. And I don't know if you've had any experience with paralyzed individuals and how much you can repair in terms of like nerves with your spine itself.
So when I was talking about anatomy in the hand, I was talking about ligaments, tendons, muscles. The neuroanatomy is very interesting too. It's very complex. So the spine, I think what you're getting at is that the spine, the neuroanatomy involving the spine is pretty complex. I feel like from a reconstructive standpoint, we know very, very little about how to. My job primarily, so I'm what we might call a degenerative lumbar and cervical spine surgeon. So I did do a lot of trauma, and we can talk about spinal cord injuries. I spent a lot of time doing that in training, but and what getting back to spinal cord injuries, though, the problem with spinal cord injuries is that there's very little you can do to a spinal cord or the nerves. I mean, you can't just sew them back together and hope they work, but you can get pressure off you. If a spine is, so a spine surgeon's job, I'm going to put it into very, very reductive terms. If a portion of the spine is dangerously unstable, either giving pain, weakness, or paralysis, you need to stabilize it. If there's a deformity, if the spine is out of alignment or has some deformity in it, if it's advantageous, you need to improve that deformity, put it back to its normal anatomic alignment. If there's pressure on the nerves or the spinal cord, your job is to take the pressure off. None of those things involve actually repairing the neural elements. I mean, we talk about repairing dura, which is the membrane around the spinal cord that just holds in spinal fluid, but that's not really repairing anything conductive. That's neuroconductive. So, I mean, the neurosurgeons are starting to do some more interesting things, but really, I mean, for the most part, and I'll talk about kind of the there's nothing really reconstructive that we do for the most part with neuroanatomy. I mean, there are hand surgeons that can repair nerves, and they do these end-to-end reconstructions, and you kind of hope for the best with those, and they just, but really for like spinal cords and neural elements, it's hard to do anything really reconstructive.
And do you see advancements in that area, I guess maybe in the next 20 years where there could be reconstructive elements?
I think the reconstructive elements are going to be more biologic than they are mechanical. So what do I mean by that? The mechanical, I mean, through sewing two things together, just putting things physically together, realigning them and hoping they grow back together. Like we do with bones all the time. Bones, we put them back into a certain alignment, a certain way, fix them, and they will grow together, and bones do great. You can do that with ligaments too. You can do that with some ligaments, tendons, things like that. Those things are highly regenerative. Nerves don't quite work like that because I don't think we understand the biologic processes by which they're way more complex. If we maybe we there's a mechanical component and where we put two neurologic elements back together, but there's got to be, we don't fully understand the biology of how those neural elements will heal if truly damaged. And we're still learning, that we're getting better and better with it, but that's something that's, I think, like I said, one of the things I loved about spine is that it had a lot of room to grow, a lot of room neuroplasticity too in the brain is something that the neurosurgeons are just, and the neurologists are beginning to understand more and more. Or is there a role? So as a spine surgeon, we deal with neuroanatomy on a peripheral basis, outside if you include the spinal cord itself, be it below the level of the brainstem. So understanding the neuroplasticity in the cord, I think, is there any? Is it prone to needing realignments or help with realignment? I think what it is, if there's a compressive component to the spinal cord or the nerves, I think that's certainly true. But things that, once those things have been really damaged or traumatized, trying to get those things repaired, we need to understand not only how to realign and stabilize those elements, we also need to understand the biologic processes that go into healing, and then maybe help with those. Time will tell. That's a really, really complicated area. It's very different in that sense than the rest of certainly musculoskeletal surgery and orthopedics.
But it sounds like it's like you said, there's a lot of room to grow in spine orthopedics and spine surgery in general. So it'd be a really cool area like in the future. And I'm not sure how they do research on this to be able to figure out certain things, whether that's like actual on people, or do they just kind of take like a spine structure anatomy? Like, how do people seem to advance the field, I guess, in a way that's, oh, they're not just trying something out brand new on a patient, but also it's like, okay, let's try and figure this out.
So the evolution of research and new concepts in medicine, boy, the pathways are so long. So it starts first with basic science research, and basic science research in biologic fields tends to first be what we call in vitro studies. So that may be at the cellular or the very molecular level, outside of tissues or organs or animals. Then you go to somewhat of an in vivo model, which can be either in tissue cultures but that's still sort of in the lab, and then into an animal model. And depending on the field of what you're trying to do, this is going to be years. Sometimes you're taking different basic science concepts that were developed in vitro, and then you try and apply those in different ways in vivo. And then once you have an animal model that is really very well substantiated and published, then maybe you can get into some FDA trials. Some places it's much easier to do those abroad. So that's it's a controversial topic, but depending on this is I'm going to be very politically incorrect, but yeah, I mean I had a attending who said, well, the cascade is test tube, petri dish, rabbits, other animals, Europeans, and then in the United States. That's, I hope, gone away in a lot of ways, but there may be some truth to it, or other places abroad. But basically, then you jump to a human model, and how you do those in the human models. That's a big jump when you go from animal to human. And there's huge guardrails, even if you are abroad now or elsewhere. And then you may have an advancement in medicine. So you can see how real big changes in medicine. Now you could start in that pathway. Let's say you already have a really great animal model, or really something that has done really well in humans, and you just want to make some changes to that and then reapply. There's some places things that you don't need it to. There are different kinds of uh, FDA clearances that don't require a new FDA trial and within significant guardrails to make advancements. Or if you're going all the way back to something that's very novel that needs is based on new basic science, that's a long pathway. It can be many, many years before it's really applicable.
Dang, that's a crazy process where you said it can, I'm sure it takes, like you said, forever. Like the animal phase itself, I'm sure is forever.
And you can
And
fail at any one of those. I mean, you could easily fail at any one of those. And
yeah,
that's the thing. That's why medical advances are so hard to come by. Uh,
because eventually it comes to us and how people go about their daily life. Because, like you said, the neural pathways in terms of the spine is so intricate that even just your hands and so on and so forth, like that can make a big deal in someone's life. And, you know, my actually, someone who was also on the show, his name was Joel Hughes. He's getting a labrum infusion. I forget which L, like between L1 and L4, I forgot what it is, but he was a Green Beret. So, as a sniper, so he worked a lot. He was laying on his back for days, hiding out in different positions. And so they told him that he would need an infusion, but as long as he regularly worked out, they could delay the process for later on down the line. And I was wondering for you and what you've seen, just how much easier is it for with people with the right physical health versus the wrong physical health that can play into your surgery role?
oh, it's massive. I mean, it's everything. You can do the same operation in two different people, and for a whole host of reasons, get wildly different results. Even if the MRIs all look the same, even if the MRI and the X-ray look
Wow.
the same. And well, I'll start with the physical elements of that, and that is what I call frailty and health, what you were just alluding to. So if you have somebody who's extremely healthy, great bone quality, they're going to heal better. Soft tissue, remember, primarily I can't heal soft tissues. I can avoid disrupting them, but in surgery, I can't fix muscles. Hard to fix the spinal tendons and ligaments. I mean, it's very hard to do that. You just don't want to disrupt them. So those things need to heal on their own when you're done. And I I can't. It's very limited what I do. I'm just again decompressing, realigning, and then fixing instability in spines. So your ability to get those things to work are based on somebody's ability to heal their soft tissues and how strong they are around them. And I can't. That's a therapy issue, rebuilding those muscles or making sure people are stronger before they go into surgery. That's therapy, that's activity. Their bone quality is something that we talk a lot about. So people that are older and or younger for that matter that have poor bone quality, when you're trying to fix things in different ways, and especially if it's a fusion, if it's reconstructive surgery, the bone quality will, and their ability to heal bones and fuse if it's a fusion is critical. The their ability to withstand surgery and the anesthetic, they really need to, if we have to look at their heart, lung, kidney, chronic disease status, somebody who's, say, your age, not that people your age are getting fusions that often, but let's talk about that was a Green Beret.
Yeah.
And I'm assuming he's on the younger side.
He's going to turn 40, actually.
Yeah, I consider that pretty young to be getting a few. And Green Beret, I'm assuming very healthy, and he's going to heal that fusion probably really well. I'm assuming he's not a smoker and a whole lot of assumptions, and he's probably going to heal that very readily and has higher odds of doing better than somebody isn't as healthy. Then there's the non-physical portion of, and that's mental attitude. Pain is real, but how your brain processes pain and perceives it is highly variable. We are still learning a lot about that, and the therapists are actually really good. Peripheral nerve education, PNE, They are really learning more and more about that and trying to work with people on an individual level. A couple assumptions I'm going to make about your Green Beret friend. They're used to periods of discomfort. Their brains maybe process pain a little bit differently. They have a different attitude about pain. Some people thrive on it. A lot of people actually thrive on pain. Uh, Talking about ballet dancers, cyclists, different kinds of athletes. I mean, they just love it. Surgeons. Um,
I'll say I thrive on it. I love the feeling.
yeah, discomfort. That's a lot of athletes. So those people are going to have a. They're probably going to rehab and do better than somebody who is sedentary, somebody who doesn't do well with pain and those sorts of things. And then there's the psychosocial aspects of there are people that don't have good social supports and how they deal with pain and stress. They just don't have a lot of help versus people that have a whole family and a community that are going to help them rebound from a big operation. So there's so much that goes into surgery and how people do
Yeah.
afterwards, other than just you can do the same operation on a very similar MRI for a very similar reason. You have very, very different results. And that's part of the art of being a surgeon is trying to build all those other things. I think that's something I feel like more of my education, more of my job is becoming, as the years go on, less and less the technical parts that are evolving are important. And yeah, I'm getting better at doing certain things. I hope to evolve year in, year out. But a lot of the evolution is dealing with those other non-surgical parts, especially the psychosocial and understanding people. It's just this idea that some people in different parts of the medical world, and certainly I think some of it's in the tech world too, and the business world, this idea that, okay, if you have a diagnosis, you send them on to that's very algorithmic, that you have a certain diagnosis, a certain set of factors that surrounding it. And if you get the same operation done by anybody at different times, that you're going to get the same result. And it it's just not true. There's all those things that I just talked to you about, and there is a human element of that. Are we going to get better with AI and different things and predictive analytics? We're trying. We're actually trying to
Mhm.
do that. So that's the frustration and the reason I think people have there's controversy about spine surgery. You say, well, why are the results so variable and why are the complications so bad? And it's like, and I will tell you that if you do spine surgery in the right time and the right person with the right expectations and the right education, that it's not as variable, and that it's also requires it's much more of a team approach. We need great physical therapists. We need great nursing around you. We need family psychosocial supports. All those things have to come into play, and they have to be to make things more predictable. And that's where, going back to my background in total joint replacements, where I started, the total joint community, they do a brilliant job of trying to look at all those. They did it far, I think, as well as anybody in orthopedic surgery. They did those things so early in their pathways back in the 70s and 80s and 90s that total joint surgery has some of the best reputations in terms of predictability and great outcomes. If you talk to people about getting a hip or knee replacement, there's not nearly the ambivalence over spine surgery. And there's some reasons for that. There's more complexity in the diagnoses, but also its expectations. And the surgeries are not as similar or homogeneous. They're more heterogeneous than joint surgery. But I still lean on my background with joint replacements in terms of how they look at problems and look at patients, and then always try. In fact, how I run my operating room is a little bit like a joint surgeon, in that I try and make it as predictable as I can, again and again. And I guess that goes back to Bill Harris in the early
Mhm.
90s.
And is that also why you want to open up your own fellowship in terms of mentoring people that are coming into the field? I had a good mentor in Dr. Harris. I want to be a good mentor to you and teach you the ins and outs and teach you more of the psychology piece that you're going to be learning and dealing with everyone.
I think most people, as they if they love what they do and have learned a lot in the first half of their career, should be spending the second half of their career or a later part of their career helping people that are new to their field and passing along a lot of what they know. I think most of us in the earlier part of our career are maybe better. There's different kinds of intelligence, and one of them is called fluid intelligence. In their better early part of my career, I think I was very quick and very good at adopting a lot of new, very innovative techniques and teaching those to myself over time, and with based on a great fellowship and experience I had. And then later in my career, I'm getting better at pulling together different ideas. I think we get wiser, and you learn from learning what you did earlier in your career, and you feel like you can help other younger people do those same things. But then you also want to pass down that what I call constructive intelligence, your ability to put together different concepts in different areas. And there's a whole other different side of it, other than teaching people about surgery. And then I talked about sort of the psychosocial, the personal ability to deal with adversity, pain, the personal psychologies, and then there's the medical. Those things I think we're doing a better job teaching in spine surgery. I think we're starting to do a better job with that. All the best surgeons I know understand those concepts are huge, and that's how they can take care of people with poor psychosocial supports that are sicker. But those of us that do that go into it with our eyes open, and we get resources for them. The surgeons they're really good surgeons who may not be as adept at picking up on those things creates more surprises and less predictability. But most of surgery now has gone towards the way we look at those issues. Then beyond that, for young surgeons, I think trying to help them with the skills that I think we could do a better job in medicine, and that's leadership skills, emotional intelligence, dealing with how do you run a whole team in an operating room? How do you run a practice? And some of it's business oriented too, but also more importantly, how do you run teams? How do you lead? How do you work with power structures in a hospital, with payers? How do you understand the economics of healthcare, which have become extremely complex, way more complex than when I started out in medicine? Those are all things that I've learned over the last, and still learning, still doing the best I can to learn over the last 25, 30 years. And I think a surgeon's ability to succeed and be sustainable and practice medicine the way that I think things should be done is really depending on their ability to understand all those issues as well. So whether we develop a fellowship or not, and I have been trying to teach those other concepts as best I can by example or otherwise.
Awesome. I really appreciate that. You're Dr. Paul, and I think it's a great story that you have. So I appreciate you spending the time here with me today, and I wish you a good one.
Yeah, thanks, Drew. No, this has been really fun and really enjoyed this. And I hope some of your listeners will find this time that we spent together fruitful. And yeah. And good luck to you, Drew. And I hope you and your listeners find this helpful.
Hey, everyone. Really appreciate you listening to the show today. If you liked the episode, please give the podcast a like or 5-star rating, depending on what platform you're listening to. Hope to catch you in the next one.